but which systems thinking has really been developed on the back of things like biological systems. How do ants organize themselves to carry a crumb from A to B and ensure that the colony all gets the benefit of it? Physical systems like how the climate works, how weather works, and so on. These are all systems that I know very little about, but again, we can use some of the same maths, some of the same thinking to analyze the physical systems, simple mechanical systems, and social systems, and that's the idea. So, as I said, all outcomes that we're interested in are the outcomes of systems. And I think a nice simple example is child nutrition. Big issue, big important problem. And certainly public health people tend to see deficits. They tend to see, we've got a whole lot of malnourished children, let's feed them. That's a simple idea, right? That doesn't reflect systems thinking. So when we think about what's happening with this rather healthy looking, well-nourished kid in the middle here, a whole lot of things are happening around that kid to feed it, right? So we've got farms producing food. Some of that food's going to factories producing processed food. We've got markets in which food is being bought and sold, and somehow or other that food is ending up inside the child. And outside that, it's an open system. We've got weather. The farm will be affected by the weather, and the food production will be affected by the weather. We've got the global economy, what's happening with inflation, with labour supply, why do people want to work in the food industry, all coming together to produce these outcomes. So in that sense, it's an open system. We can think about what are the factors affecting the weather as yet another system beyond that. Oh, sorry. You've got one of these ones that reacts if you touch it. I'll need to be careful. We've got all the factors like war in Ukraine affecting what's going on in the economy. So it's an open system, and it's a nested system in the sense that we can put the kid in the middle, around it, the farm, the food, the factory, the market, around the market, the weather, the economy, around the weather and the economy, climate change, war in Ukraine, until we're looking only at great big global forces that are shaping all these things. And if we take the view, which is the kind of what I'll characterize as the kind of naive public health view, I'm not suggesting that all public health people are naive, but sometimes the starting point is a bit naive, that says the kid's malnourished, let's feed it. You are not thinking about how you make sure that you're not knocking this system out that's feeding all the kids, right? So the classic thing is, you come, you bring a whole lot of plumpy nut or something, you give it to the kids, and some of these markets break down because they're not buying certain foods that kids need because they're getting the plumpy nut instead. When you go away and your plumpy nut disappears, suddenly there aren't the infant feeding products in the market or the other things that kids need in the market, and you've created a problem rather than solved the problem. And what we find again and again when people use that kind of simple thinking, there's a deficit, let's fill it, let's bring a program that will sort this problem out. As soon as that program goes away again, everything goes back at best to where it was before. And sometimes that program has undermined how things worked before, which is why it's really important to always be thinking, not so much about the deficits, what's the problem, but if we've got malnourished kids, let's look at how they're getting fed, first of all. They're alive, so they haven't starved to death, they're getting fed. How's that happening, and how can we reinforce the good things that are happening, the way things are working positively, rather than just replacing them and assuming that somehow the rest of it doesn't matter very much. So, let's think just a little bit, some technical language that I just want to dispense with before getting back to some more interesting things. One of the things that's going on in those systems is that not all the relationships that are going on are A causes B, or a bit more of A produces a bit more of B, or what we might call linear relationships. Some of the things that are going on are more complicated than that, and that's why a lot of systems, and again another bit of language that I'll talk about, is a complex adaptive system, in which lots of things are not linear and lots of things are adapting to each other as the system works its way through. So very quickly, not possible to go into these things in great depth, but one type of nonlinear relationship is path dependency. If I try to move from C outwards, it makes a difference that A happened before. If I went from A to B, I can only get B1 and B2. I can no longer go to C1 and C2. So a typical health system example that I use for that is that in the US, they've allowed their private sector to dominate their health system. It has made the health system it has made the private sector in health very powerful. So you can't go back and have an NHS anymore. The political forces will no longer allow to have that publicly driven health system. And their options are really about how they can manage the private sector to allow them to do a bit more controlling prescription costs or a bit more management of volumes of technology. They don't have the options that India has or Britain has to move towards a more complete public system if that's what they want to do. I'm not saying they do want to do it, but if they want to do it, it's constrained, right? Scale-free networks are another type of relationship where the people or the entities and the parts of the system that you want to influence are differently connected. So you can see on this, you've got some hubs, you've got some spokes. It might be a bit small for some of you at the back, but it's you've got an entity up here, whether it's a person or an organization or an ant or whatever, that doesn't speak to as many other ants or other institutions. Oh dear, keep doing that, don't I? And you've got other ones that are very well connected and link into lots of other of the entities that we're interested in. So again, I'll give you a health example. If you're trying to run a health education program, you could be talking to all these people around the edge, and your message will barely get any further than just those people. But if you focus on the hubs, it's far more likely that they'll spread your messages around. So each unit in the universe isn't the same. Some are going to have much bigger impacts on your outcomes than others. Phase transitions, also called tipping points. Some of you know the Malcolm Gladwell book, which is about how a trend, for example, can get going, and a group of kids in a school can all start doing something, and it can die there, or it might spread to another couple of schools. And at some point, everybody's using a hula hoop, or rollerblades, or something, because it's spread from just those few kids out to everybody. And there's some tipping point at which it becomes really, there isn't a kid in the country that doesn't know that they want inline skates for Christmas or for their birthday or whatever. Feedback loops, X causes Y, then Y causes Z, and then Z influences X again. So lots of economic examples of that. Something causes prices to go up, prices going up make demand go down, and so on, and that feeds back into the price again. So lots of feedback loop relationships. And then finally, emergent behavior, the sense that out of all these relationships, outcomes kind of emerge. They're not really caused. And I think this is something that's often quite difficult for some branches of economics to grasp. I get very frustrated, especially with econometrics, with this obsession with identifying, is it a causal effect or not? In my view, the world doesn't operate through cause and effect. And I think that's very naive economics, actually. What happens is all sorts of things interact with each other, outcomes emerge, and nothing really caused those outcomes. Different factors influence them, but they influence them through multiple pathways. And one of the problems with the naivety of that is that the idea is that if you did an intervention and it produced effect X this time, that you can do that intervention as many times as you like, and it'll continue to produce effect X. Think about path dependency. You've already done that intervention before. Maybe people are bored of it. Maybe people are frustrated at it. Maybe people who don't like it will be better able to resist it. So just this assumption that you can just repeat things and get the same outcome, I think is a naivety that some of our economist colleagues are guilty of as well. And then I think most of these things I've already referred to now, but let me just go through them as well, just to get the language. Equilibrium, we think about it in economics and we normally expect markets to produce stable equilibria. We know that there are contexts in which markets can produce unstable equilibria, but this is a nice way of picturing stable, unstable, and I can't remember the intermediate equilibria, just in the terms of physical relationships. Here you've got a ball bearing and a globe, if you like. If the globe is stuck, you can flick the ball bearing from one place to another, but it's always going to end up back. And that's what I see when you've got a difficult situation like a lot of child malnutrition, and you come along and feed them. You're flicking the ball bearing, but because you're paying no attention to the shape of the globe, if you don't mind me, so probably overusing the analogy, as soon as you're gone and your plumpy nut's gone, at best everything goes back to where it was. Here's the opposite. You come in, you do something, the ball bearing just falls off that and rolls away, and you completely upset the apple cart. That ball bearing is almost never going to be able to stay there, because even the slightest nudge to the system is going to send it away. And this one's much more tractable. You can put the ball bearing where you like and it'll stay where you put it. Now, in economics, we tend to think stable equilibria are good things, right? So, in my view, in health systems, equilibria are often keeping things in the wrong place. And so I use the term stubborn equilibria rather than stable equilibria, because everyone's trying to move this ball bearing. It keeps going back to the problem place that it's in. And part of the problem, in my view, is that people are focusing too much on the ball bearing and not enough on the globe it's sitting in. And we need to think about the system structures that are around the problem and influence those, change the shape, break it and throw it away, whatever you need to do. Again, overusing the analogy. Closed systems and open systems. The coffee grinder is closed. Nothing much is going to influence whether when you put the coffee beans in and turn the handle, the ground coffee is going to come out. Not entirely true. We can think of all sorts of, if you try and do it in a hurricane, maybe it won't work or something. But generally, you'd call that pretty closed. As I explained already, this is an open system. We can really keep going up and find more levels of the system that are going to be influencing what's going on at the level of the kid. Also, that system is nested. We can think about the kid. We can think about the agricultural and food marketing system. We can think about the economy. We can think about the weather. We can see each system is nested in a system around it. And health systems are generally agreed to be complex and adaptive. You can find all sorts of little diagrams of complex adaptive systems that people have drawn. But you've got the kind of hubs and spokes and interrelationships between components going on, processes of self-organization. It's not all about, government doesn't come and put all these things in place, put some rules in place, and the parts of the system organize themselves. We've got information coming in and out that people are acting on, that they're adapting their behavior based on what they understand is going on and what they think their interests are. And that behavior emerges from all these interrelationships. So complex adaptive systems just means there's lots of components, there's lots of different kinds of components, there's lots of different types of relationship, all those kinds of sort of non-linear relationships going on. The critical thing is emergence. We don't have cause and effect. We have outcomes that emerge from all that interaction, and people it can be ants, it can be bees, it can be it's mainly going to have some kind of social organization or adapting on the basis of what's already gone on. So you can't expect the same response time after time. Just to reiterate, to my mind, this is the major issue that we face in health systems. They're stuck in stubborn equilibria, and our problem is to try and resolve that. So here's just some examples of some of the things that just to illustrate the idea that we have a whole lot of stubborn equilibria in health systems. Really, Kathy, when I do a lot of work on, as Professor Rudker mentioned, human resource issues. Most people think the solution to shortages of human resources in country after country is to work out how many of what you need to train and train them. They do that. I've been in Indonesia myself, trying to get them to think a bit differently, but what they've wanted is the numbers that they can put into their machine. They get different international consultants coming year after year, giving them their numbers, and they never move any closer to having those numbers on the ground or resolving the shortages. So why is that? But it's not just a simple question of training more health staff and they'll be there where you need them. Whole lot of reasons that we can think of as being something like this. We can think about it, we maybe come back to it if we have time at the end. Now the problem, everybody thinks hospitals are best, right? Politicians think they're best, patients think they're best, staff want to work there, and yet if we can't get away from the idea that good healthcare can only come from hospitals, we'll never afford universal health coverage for everyone. It's too expensive, and it isn't actually best because hospitals send you off to specialist departments when you might have complex multi-morbidities that need generalists that can understand how those are all coming together for you, that can think about the fact that you have a disability, so maybe they can't just send you a standard exercise sheet to resolve your cardiac problems, that can think about things together. Hospitals don't do that. So again, you can think about why that's a stubborn equilibrium. Why, when everybody believes that hospitals are better, when people want to work in hospitals, they don't want to work in primary care, it's very difficult to get a primary care-based system going. Similarly, perhaps, most people agree, prevention is at least usually better than cure, and yet every health system that I've ever come across puts all its resources into cure and leaves the dregs for prevention. Why is that? Again, stubborn equilibrium that is very hard to knock out of shape. So I want to think a bit about the project that we're working on, or one of the projects that we're working on in India at the moment, to sort of illustrate how we can sort of think about this and try and get beyond the we need a simple intervention that solves the problem and has a cause and effect kind of approach. So let's start. We've got people, there are people who aren't very well here. We can see they've got a range of health problems, and they're thinking about how am I going to navigate my way through the health system. And they've got questions about how far away is it. They've got questions about quality of care and where's the right kind of care for them. And they've got questions about how much it's going to cost them. And then over here, they've got a whole set of options. They could go to a public hospital or a private hospital, public or a private pharmacy, a clinic, some market stall that they can pick up some pills from. And they're juggling all those things. It's a market, basically, right? And for each of these things, there's a distance, a quality of care, and a cost. And they're juggling all that and trying to work out what to do. Please.
Can we ask you questions?
Yeah. Go ahead, I'm happy to take
clarificatory question.
Yeah.
How do you define public and private in this slide?
So I'd say public is government owned, to be straightforward, and private is privately owned. Ownership is the usual criterion for government.
So the doctors are also government employees?
In India, that's the case, yes, and we're talking about India, yes. So that's not always the case. Some public hospitals in the US have a different relationship, and they're certainly not civil servants, the health staff in them. But let's say ownership, just to keep it simple. So this stubborn equilibrium that we encounter, not only in India, but in lots of countries, is the public sector has a bad reputation, often a very well-earned bad reputation. It's underfunded and it's unpopular. And it's a kind of last resort. It's used by the poor because it's usually cheaper. It's used by people who can't travel very far because there's more often a public clinic in more remote areas than there is a private facility. Although there's often in more remote areas a choice between this and this, a public clinic or a private drug seller or informal provider of some kind. And the private sector is expensive, it's exploitative, and it's unregulated because it's virtually unregulatable. regulating the informal sector in healthcare is a bit like trying to regulate recreational drugs. There's a willing buyer, there's a willing seller. They're very happy to hide themselves from you if you're the regulator. And there are thousands and thousands of them. And your regulators are, you can count them on a hand. Right? So it's virtually unregulatable. And the critical thing that makes this a stubborn and, in fact, a vicious circle, if you like, is that in order to attract these people here, they only have to be slightly better combination of the distance, money, quality of care combinations in the way that whoever it is weighs those things up than here. So if you take the view, as is a common view in India, and not only in India, but a common view in India, we've given up on the public sector, it can't deliver anything, we're not going to bother about financing it. The quality goes down and down here, and that allows everything to come down and down here as well, so that they can be more exploitative, they can be poorer quality, and they don't need to make much effort to get near to you, because this is getting so bad that you still have to come here. And there are all sorts of reasons for people who are doing health economics that we also understand that the market doesn't work well in health. So the general expectation that the competition between private providers will discipline the market won't work for a whole series of reasons that if you've been studying my book, you'll know that. So this is a typical, but also particularly Indian problem. India is outlying in two respects. One, in it's very low public expenditure on health relative to all your middle-income neighbours. You spend much, much less. Hence, you have this problem to a degree that other countries don't have. And I would say that you have an outlyingly dysfunctional health system, and I think the two things are related. So that's kind of the background to the sort of analysis of what we think we're studying when we come to this study that we're doing, understanding 4 different Indian health systems through understanding their health-seeking behaviour. So what's driving that previous slide, right, is all about where people decide to go and why. So we can compare different states in India and look at how those patterns are different and see what it tells us about what's going on. The states we're working in are Punjab. I'm sure I don't need to point at these. I'm pointing at them for my own good more than anybody else's. Uttar Pradesh, Maharashtra, and Odisha, or Orissa, whatever you call it. So it's work in progress. I'm just giving you some nuggets. We're yet to call anything very much publishable, although I'll show you one of the papers that we published on it in a minute. But the question, or one of the questions, is, does investing in the public health system, as the previous slide would suggest, improve health system access, quality, and affordability for the average system user? And why I put the average system user in italics is because many analyses of what I might call the more naive kind look and say, well, we're investing in the health and welfare centres, for example. Let's have a look at the quality of care they're delivering, whether people like them or not, how many people are using them. But if we don't ask that question about the average user, who's not using them and why, is it only middle class, better financed people who are using them if they are delivering good quality? Are they displacing poorer people? What's happening to those poorer people? Where are they going? So we have to think about the whole population of users and not just zero in to just one part of the system. And we have remarkably few tools to do that in health systems research. So part of the idea of this project is to think about whether health-seeking behaviour measures can be among those tools that can help us look at this at a system level. And then our key indicators that we're interested in is the use of what we call small private clinics. Nobody knows if they've gone to an informal provider or not. They've all got certificates on the wall, right? Some of them are real certificates, some of them aren't. So we can't ask people, did you go to an informal provider? But we know that some of the major quality problems, not all of the major quality problems, but some of the major quality problems are in those small private clinics. They're more likely to be actually actively giving people dangerous interventions, for example. The length of the treatment-seeking journey, people zigzag, as one of our Gates Foundation funders calls it. You know, they go from this place to that place to this place to that place, looking for what they hope to find, rather than knowing they can go to one place and get the right answer. And in particular, some of the work that Sumit in particular has led shows that when people start to get a chronic illness, they start to have breathing difficulties, or they start to feel unwell in ways that you know, grow up on them rather than sort of suddenly strike them one day. They assume to start off with that they've got a curable problem, we all would. They do a lot of zigzagging around. These small private clinics in particular will drain their resources. And only when they start to run out of resources do they start to think, I don't think I'm going to find a cure for this. I'd better find a long-term solution that's manageable for them and sustainable. And often by the time that they've done that, the family is impoverished in ways that's hard to recover from. So when you think about, you know, how many households are going to have somebody with a chronic illness, pretty much all of them, how often, this could happen to the average household maybe every 10 years or something. So that you can see that there's a process by which households are held back in poverty because of these issues. So the dysfunctional health system isn't just an issue, it's just an issue for infant mortality, maternal mortality, the overall health of the community. It's actually a really major poverty-related issue as well. And the other reason why it's a major poverty-related issue is just the levels of out-of-pocket expenditure. And as you know, Indians spend a lot out of pocket, and that compensates for the very low levels of public health expenditure to some extent. But we know that's bad on many levels for all sorts of reasons. Okay, so a few nuggets of some of the results from what we've been doing. This is just a big number crunching exercise looking at the per capita health expenditure, per capita public health expenditure, state by state, suggests that even a pretty small amount of extra money in the public sector has a big effect on people's use of the small private clinics. So an extra 100 rupees per capita in a population, depends on which model we look at, which population we look at, but across the range of estimates, reduces use of the small private clinics by between 9 and 23%. That's pretty phenomenal, and I think it shows that you're at a stage of your public health expenditure is so low that even small additions are really measurable and really perceivable and make a big difference.
And the implicit assumption being that this is desirable?
Yes, well, I made it an explicit assumption 5 minutes ago. But yes.
Because so the implicit assumption is that the private clinics are bad quality.
Yes, that's where the...
Do you have an independent verification of that?
We know it's where the bulk of the most dangerous care happens. Right? It doesn't mean that every private clinic is a bad experience.
Is there some independent evidence or a research paper which documents that private clinics are bad people?
Not bad people, not necessarily. But one of the things that, one of the kind of ideas that we put forward in our UNICEF Health Systems Training course is that human resources for health professionals are neither robots nor angels, right? They're just like the rest of us. They're trying to get by. And if you're a poorly resourced, possibly fake, unqualified provider, you're just trying to get by, right? And but in the process of trying to get by, and you may or may not know it, you can be offering not just unhelpful and money draining, but dangerous responses to people. So I don't know. A colleague there are plenty papers documenting all this.
I don't want to take too much time. Just one more minute on this. So if I had rupees 100 with the government, should I invest it in increasing public expenditure on the public health facilities, or should I spend that money on better regulation of these private clinics?
Well, you can conclude, but as I said already, I think these are unregulatable. They're as unregulatable as recreational drug trade. People want to use them, they want to be used, they're out of sight. You've got how big a workforce in your regulation sector, and you've got thousands of these people. it's in my view, it's unregulatable.
Sorry, I'm hogging the time.
No problem.
In India, there was a big issue of determination of the sex of an unborn child. So, it's banned officially. A doctor is not allowed to do those tests which tell the parents because there's a danger of female feticide. So, various things were not working, and there are a lot of private good doctors, not necessarily shady doctors, who were doing it. So, in one particular district of Maharashtra, this state, they actually installed a CCTV system as a part of regulation, which I'm told improved the compliance of this law. So there's an example where money could have been spent on something else, but they spent it on regulation.
Yeah, I'm not saying nothing is regulatable, but you're talking about facilities of a level to have the equipment to determine the sex of the child. There we're not talking about thousands in a district, but maybe 100 or so, I don't know. But here we're talking about thousands of people, some of whom are moving around villages with their stock of drugs, which will obviously be the right thing for whatever condition they're confronted with. We're talking about shops that sell a few pills. We're talking about all kinds of medical traditions, if you like, your Ayurvedic, your homeopathic, all those things are all going on, and they're just thousands and thousands. And you certainly couldn't afford a CCTV, and just to cover send them around. So I think it's unregulatable, but that's a proposition that we can argue about. And then the second point here in this paper is that these effects were bigger for the poorest and the lower caste people. And then the other thing is that from our state comparison is that Odisha is really interesting. And our data suggests that the higher level of public investment and better quality of public governance probably in the Odisha health system decreases the use of the private sector, decreases the length of the treatment-seeking journey, and decreases out-of-pocket spending. Again, it's preliminary. We've not published this, so much more yet to be fully explored. And one of the things we want to do when we come back is invite people from the 4 states to kind of to check our idea that this is the case, that Odisha is both investing more and governing better its public health system. But if it is, and if we can get to the bottom of that and be sure that what we think about that is right, then it's pretty powerful stuff. I think that the argument that investing in the public system is not at all a waste of time and they'll never be able to do anything, but actually extremely good value for money for the health system. Okay, so just want to close on what's the sort of generic message from that. I think we're trying to make that thinking come to life in the context of the health-seeking behaviour in 4 Indian states project. And as I say, I think the example here is that this argument of giving up on the private sector is not only a bad argument, but actually catastrophic. It's the driving force of the dysfunctional health system in India, and we need to change that narrative. And we've been doing quite a lot of talking with lots of different people that we've been meeting this week about how do we change that narrative, how do we get those results and that thinking more widespread among the people who are influential over this space. And of course, there's a wicked problem or a stubborn equilibrium in that as well. There are a lot of strong forces that want that to be believed, because that's going to leave the market free for the private sector. So now we're not just talking about the little private clinics, but the Apollos and so on. They don't want investment in the public sector because it leaves the market free for them. So we're in a bit of a stubborn equilibrium about the discussion, a bit like I said at the beginning about the US system, that some of the actors are getting too powerful, but you're still nowhere near the US. So I'd say, treat this urgently. Don't let yourself get into that situation. And it's a specific example of the rationale. You've got to change the globe, not the ball bearing, when you've got one stubborn equilibrium. When you just target the ball bearing, it's hopeless. It's just going to end up back where it started. You've got to think about the system around the problem and how you reshape it to get the outcomes that you want. So the outcomes you want emerge from all that, and not just think that you can come in do an intervention, shift the ball bearing over here, and it will stick when you're gone. But we can think about what those might be, for example, for some of these other problems that I talked about up here. If you actually wanted to unstick these, what's the system around them? What would you have to change so that you actually get better outcomes in relation to those things? And if you can do that, you're doing stuff that I don't think anybody's doing very well, because there just isn't enough of this thinking in public health. Thank you.
This is a great talk. Thank you so much for it. I have two questions. One is, I failed to see how the systems thinking came really into the picture when you talked about the intervention of increasing the expenditure by 100 rupees per capita. Because it seemed like
So nice cause and effect.
and again, it seemed like a direct intervention that led to an effect. The second thing is, in your system that you also showed earlier on about child nutrition and when you were discussing this, one thing that I did not see an element being there is the political economy, right? Here we are sort of assuming that we want some money to be spent. We as academic researchers would want the money to be spent in one place, and if the money does go there, then we could see results of say 90 to 23%. But how do we expect the political economy infrastructure, given their own interests that might be involved, to deliver these results for us?
Yeah, I think those are both excellent points. And if I go back to this, I think the paper, the published paper, is published. It's an econometrics paper. You're stuck with these ideas that proving cause is the important thing, and in fact we do all sorts of things with the maths there to say we've proved the cause. But I don't think I don't think it's a simple cause and effect. I think what's going on here is this analysis would suggest that if we change this, better things will emerge, right? These things, improvements here will emerge. So I interpret that data to say that if you spend the extra 100 rupees, you've got a good chance that some of these outcomes will emerge. But the fact is, if you look at the paper, it's written as an economics paper, and therefore we've had to agonize over proving that there's a cause and effect, even though I agree with you, I think that's nonsense. Then in the political economy, I think I've hinted at political economy a bit in relation to talking about powers of the private sector voices and so on. And clearly that's part of the political economy that goes around this. We're actually thinking about the next project for the Gates Foundation. We've been thinking about the political economy in a lot more depth. So another piece of research that I didn't mention that a colleague of ours is doing is looking to see why are public sector health institutions not responding to PMJ. They're supposed to see it as an opportunity that they can get more money from the public insurance system that's been set up around PMJ. In other countries, that kind of thing works. If you give public sector institutions the opportunity to earn more cash so they can do some of the things they want to do, improve their environment and so on, it kind of works. I mean, not always the same way, not identical. In India, it's really not working. The private sector is interested in PMJ, but the public sector isn't. And it turns out from our colleagues' work that this is about extreme risk aversion in the public systems in general. That you can't ever really be criticised for doing nothing, but try and do something and you can run up in a lot of trouble. It seems to be the culture of the public sector in this country. So some of our discussions are really about, is that shifting in India? You'd think it kind of would have to be, because the society is transforming from this type of society that produced that kind of public system to a completely different modern society. But how is it changing? Where is it changing? Can we see, are there some examples of some parts of the country where the public sector is really transforming and civil servants are being a lot less risk averse? So I think we're thinking about political economy issues, and of course there are many, many dimensions of them, but not having said so much about
I'm curious to know why, in your analysis, why does this particular equilibrium is stubborn? What factors make it stubborn?
I think it's a bit similar to the hospital one. It's a kind of everybody knows thing. Everybody knows the public sector's rubbish, right? This narrative that we've tried the public sector, it's failed, even though it's never been very well resourced in India, is very dominant. So there's a lot of people's thinking that will have to shift to get the political economy to operate so that the extra resources are put into the public system to demonstrate the opposite of what everybody knows, which we can actually see.
Crisis of image.
Image, culture, attitudes, I think, these things are all interwoven, aren't they? But I think that's the major driving force of this equilibrium being stubborn. Everything that makes it difficult to persuade state and national government to dramatically increase public sector funding is embedded in that equilibrium.
I have a related question. You see this kind of reputation of is a kind of a middle class perception. It's not an perception of diverse population in terms of economy or in terms of even social status. So the paper which you talked about in the other paper,
Yes.
which you quoted, most of the lower caste and even scheduled tribes, they opt for public health systems. And there is also a contradiction out here. We have the best medical colleges which are public, and yet this perception about public hospitals. I mean, they are linked to each other. If you see, Sassoon Hospital is a government owned, and you have also the Vijay Medical College, which is associated with it, which is a public one, but it has a bad reputation. But I think it is a middle class kind of a perception. I hope if you take a perception of those who avail it or access it, maybe that demystification can be done.
I think you're right. I think the problem is that it's the middle classes that decide that it's not worth investing any more money in the public health system, right? But we have also been running into this issue of whose perceptions are we picking up as well, because in choosing those 4 states, I didn't even mention it because we don't believe it anymore. We thought we had 2 states with bad health systems and 2 states with good health systems. Looking at them in more depth, it's not true. If anything, the best health system in terms of the average experience is probably Odisha, where we thought it was a poor state. We thought it didn't have a good health system. We expected a lot better of Maharashtra. And it seems that those kind of ideas, oh yes, these rich states have got good health systems, are based probably on what middle class people can access. So in Maharashtra, you've got some very nice hospitals, public hospitals in the cities, but the people we're talking to in the remote villages, that's irrelevant. Right? So what they can actually access looks pretty similar in all four states. So we've kind of abandoned what was part of the initial premise of the study, that we had two good health systems and 2 bad health systems. And now we're just trying to figure out what to learn from the comparisons between them more generally. But you're right, people have different attitudes in different places, and those attitudes have different influences over policy. And then I think picking apart whether people like the public sector or just rate that its particular characteristic of being much cheaper is really more important than everything else is another question.
I just had a question about the term that you used, stubborn equilibrium. When we speak about stubborn equilibrium, especially in the context of health, and we try to take a systems view, the problems that we try to solve, the other stakeholders, are they themselves not a part of stubborn equilibrium?
You're absolutely right. I mean, clearly, a big part of the stubborn equilibrium we're talking about here is policymakers' attitudes that spending more on the public system won't. So we have to work with that. That's part of what we've been
So
strategizing.
is this just that incrementalism? I mean, is it possible that incrementalism at the periphery and then that results?
I think we just need to convince the right people that they've got the wrong idea. I don't know, just, you say, just. But that's what has to be done, right? And standing here talking to you now is partly about convincing you all that narrative that the public system is a waste of space and just should abandon it and let the market do it is a really catastrophic idea. So you can try to.
I have two comments to make. One comment that I would make is, yes, you talked about stubbornness, but I think the idea that markets fail is also a bit of a stubborn idea. It has stuck in minds of people, and I think there is time to revise that thought process, because it has really been there for more than 30 years, that markets fail, markets fail, markets fail. Nobody has thought that whether markets could work. I think it's time has come to revise that. That is one comment. Second comment is, yes, of course, increasing public health spending would definitely reduce this thing and improve the access. But it can be seen as increasing the competition. So if the government is also a significant market player, then again it is making the markets work. And by that mechanism, definitely the output that you expect would be there. But we must understand that it is by making the markets work in a better fashion, because government is a significant competitor now.
Okay, so I thought I was going to disagree with you quite a lot. I'm only going to disagree with you slightly, because the point here, what we call this model, I haven't actually used the term here, is regulation by competition. Exactly. The idea is that if you can exert competition from the public sector, you can make the private sector work much better. So it's not about trying to get rid of the private sector. It's about saying that investing in the public sector improves both, right? Improves everybody's experience. But I think if you want to argue more generally that markets don't fail in health, then you need to assemble some evidence. And a number of bodies have been pushing that narrative for the last 30 years, like the World Bank, like the International Finance Corporation, and they've really failed to establish a good evidence base to suggest that somehow or other that's a mistake. But I think you're absolutely right. This is about disciplining this stuff by investing in this stuff. So it's a double, it's not just about having everybody use the public sector. It's about saying this will be better if this is better. And I'm going to go to him first, because he's...
No, my question might be a slight deviation from the topic we just discussed. Like, but I'm just inquisitive to know your perspective. Like, for example, like in India, every year around 5 million deaths happen due to medical negligence. So do you think, it's a very pressing concern, so do you think investment-wise what can be done, like into some specialized courses or something like that?
Well, so I think it's a product of this. Have I still got this one up? Yes. You know, if this is really bad because it's underfunded, you'll get, I don't know, medical negligence is a big term, but you'll get deaths that needn't occur. And if this is undisciplined and exploitative and can offer really poor quality of care because people are stuck with it because they've got no alternatives, you're going to get medical negligence, unnecessary deaths. So while there are all sorts of technical things you can do, like you're suggesting, you know, sending people on courses, I think most of us are economists in the room. We believe that you really need to get incentives right to deal with things. And then if I have a strong incentive not to kill you when you come to see me, I'll maybe decide I need to invest in my own training or something. If I have to pay for you to go on training, clearly the incentives aren't lined up for you to care what's happening. So I would say get the incentives right first, and then make sure that the technical opportunities are available so that people can invest in their own ability to follow those incentives. And that's an oversimplified answer to it.
Because 5 million is
it's huge.
It's very huge.
A lot, and this is what I was saying before, a lot of it is happening here. I heard a colleague of mine is an anthropologist who works in a village in Uttarakhand, talked about someone who was given horse medicine instead of human medicine by one of these itinerant drug sellers and died straight away. I mean, you know, that sort of thing probably never even gets documented. But, you know, the ones you're counting are 5 million. Sorry, can you go ahead?
Okay, good question about, you talked about this model as regulation by competition. My concern is, this regulation by competition could instead make the market uncompetitive by leading to the exit of private clinics. I know we are holding the assumption that private clinics are bad, most of them, probably more than the average. But within the whole framework of systems thinking, where there are complex elements involved, how do we know that increased public expenditure is not going to lead to the exit of the good firms and make the bad private firms will survive?
Because the good ones should be better able to compete. And the worst ones are the ones people are going to vote with their feet to go to a better public. Psychology. It's not going to be perfect, of course not. It's about the average experience.
Quick follow-up. But if you're saying that the market doesn't work, it's essentially the same thing as voting with your feet is not working.
Okay, so I think there's a complicated discussion about how the market doesn't work and why and in what respects it doesn't work. The kind of simple health economic story, as I'm sure you all know, is that is information asymmetry drives market failure. People make bad decisions because they're not expert. But I actually think people make good decisions on many, many variables. So especially poor people are very careful what they do. And they agonize over whether to spend it on a bus trip to the city to get to a better public facility or to spend it on a local jolly chap in one of our states, they're called. And people make decisions with their eyes open about the quality problems that they're likely to get. So they know if they go into spend it on the journey into town, they might get very rudely treated, which is very unpleasant. They might not be offered much in terms of the kinds of medicines that they're looking for. And if they go to the jolly chap, it might be cheaper, but they know that it might also be dangerous and not safe. And their child's survival well-being is at stake, so they take it very carefully. So if you make that public sector a bit better, you have people being polite to people, and you have a wider range of intervention, because one of the problems of the public sector in India is it's a very narrow range of things, really often with children. If you're an adult man, forget it, right? Pretty much. So widening the range of things they can do, these are things people will notice, and the people they will avoid will be the people they know are dangerous. So there is information asymmetry, but it's not total. And I think on the whole, you will obviously have some errors, you'll lose some good private providers, they might direct people to the wrong public providers, whatever, but I think in terms of average experience, I think it should work.
At the start of the presentation, you said that we had a particular problem about being hospital-centric, and you also say that private clinics are bad. So what's your alternative to combat both these things?
Your health and well-being centres, invest in those, make them really good, make them capable of dealing with the burden of disease that India has now, which is not the burden of disease it had when the public sector was constructed in the 1960s, 50s, which, you had a population pyramid like this, right? Nearly all your health problems are with children, reproductive health. Now you have a population pyramid like this, you have a huge burden of diabetes, lots of chronic ill health, and the public system is not responding to that at all. So these health and welfare centres, which are designed to do that, are exactly the right intervention. My worry is they won't get the investment.
Sorry, a follow-up on that. But what I understand is the burden of health problems that we face now, which is diabetes and BP. All these are middle class, I would say, higher income,
Yes.
Upper middle income people, and then
They're concentrated at that level. So this is another program of work we have in the Institute, actually, which is as your economy develops, the gradient switches. Right? So in the UK and Australia, chronic ill health, non-communicable diseases are concentrated in the poor population. In India and China, they're still concentrated in the rich population. But if you're thinking about the health system that needs to be in place in 20, 30, 40, 50 years' time, it's no longer, even if you focus on that switch now, it would forever be a switch that will favour the upper classes. And then having said that, our research is about people in remote rural villages and in poor populations in urban areas to some extent as well, and we're finding plenty of these conditions. And they may not be as prevalent as they are among the rich, but they're impoverishing. So it's not just about the burden of disease, it's about the impact on people's economies. And if we don't tackle chronic ill health in the poor population, they're going to be continuously impoverished by it. Because it's not like when you used to get malaria, you could go to the clinic, maybe spend a bit of money, but come back with a cure. You've got to constantly keep paying for this stuff. So if it's too expensive and it's not efficient, it's really crippling the whole household. So I think we need to, you're right, but I think we need to think a bit beyond that. So.
But I also, so sorry.
Yeah, no, please go.
But if it is not hospital centric, and because before we knew that there is malaria, there's dengue, and then most impoverished people will go and that's what they will have. And now, as you say, there is a host of other diseases. You need specialists and.
Not really. So take diabetes, for example. If you have never been tested for diabetes, you don't know you're sick till your disease is really quite advanced, then you end up in the hospital. But if you have a good primary care system, you get your blood sugar tested, you see that it's rising long before you get sick, it gets managed, you get on pills that the primary care facility can deliver, you never need to enter the hospital. That's what you're trying. So it's mixed in with the prevention thing. It's called secondary prevention.
Yeah, like you said, I guess the Delhi government is already implementing Mohalla
Yes.
right? But we, take a portion of investment for Mohalla clinic, and the private where they operate their own. I guess there is a mismatch in that. So how you want to tackle that issue?
So I said what Delhi is doing is a bit like an advanced guard on the health and welfare centres, isn't it? Lots of public clinics, hopefully near to people and so on. And my worry is that the investment isn't high enough. Delhi isn't one of our study areas, so I don't know how much they're spending, whether it's enough, whether they're good, these clinics or not. If the clinics are good in the ways that I described, if they're nice to people when they come through the door and don't treat them like some kind of second-class citizen, if they have a range of services that's wide enough to cope with the burden of disease and aren't just interested in women and children, and if they have the facilities, that means the equipment to test for blood sugar, the diabetes medicines and so on, then they will improve the system in Delhi, I'm convinced. If they're not, if they're underfunded, if they've still got health staff who feel underpaid and abused, then that's what causes people to abuse other people when they feel abused themselves. If they're still only offering things for women and children, then it won't have that effect. And I'm afraid I don't know which is happening in Delhi. You guys probably have a better idea.
I agree. It's the system's problem. When the government is putting a system, then for same amount of operations, the cost is much more than getting it done from the private clinic. So this Jan Arogya Yojana, they are doing the same thing. They are reimbursing the private clinics so that they don't have to pay for that system, because maintaining the government system is being more costly. Because they have pensions, the pay system is not flexible. The private, the payment system is flexible.
So there's a whole body of literature and research around public paying the private sector to do things versus the public sector doing it themselves. Works in some places much better than others, and the sort of headline conclusion from all that work is it's just about as difficult to buy things well as it is to deliver them well. So there's different problems often. They may pay too much because, again, they're not very good at contracting, so the private sector takes them for a ride. They may not get the outcomes that they're hoping for because the private sector takes the money and maybe doesn't do the work. How can you measure whether they're doing the work or not? Are you good at monitoring? So these problems of purchasing and managing contracts are as complicated and difficult as the problems of delivering. And sometimes, in some places, the balance works. It's good to buy In other cases, it works, it's better to provide, because those things are variable. Maybe last question at the back?
This was a really insightful presentation.
Thank
So,
you.
My only question, I have two questions actually. So when we say that a stubborn equilibrium does exist, do we define it as status quo? Does it persist? And if we do in fact believe that in principle there is a stubborn equilibrium with regards to the public healthcare in India, aren't we undermining the very characteristics of markets being adaptive and complex? My second comment would be that it was very rightly pointed out in the presentation that we have the bad reputation of the public sector is very well earned. I really hope that once the project is completed and there would be many areas that would that the project would explore with regards to how tiered this bad reputation is. We in fact are moving, as somebody who's followed the public health sector very closely for about half a decade now, I would say that it is very tiered, and primary sector is in fact emerging as one of the strongest pursuits of the National Health Mission, which is the flagship program of the Government of India Health Program. We are, the doctor population ratio is better than before. The investments in preventive care is, the health system has responded to it really well. So I really hope that the study does take that lens to it in defining that. And I would only request the answer to the stubbornness and the point of definition, the time frame for it.
Often well earned, right? I completely agree. There's some excellent public sector facilities in India. I visited CMC Vellore not long ago, and clearly one can't just tar the whole sector with that kind of brush. On status quo, it just means the way things are, of course, but often what people mean by status quo is something like a stubborn equilibrium, how difficult it is to move on from the status quo. And then finally, missing out on the capacity for markets to solve problems. This is actually making the market solve the problem. At the moment, it's not solving the problem, because while it only has to compete with very poor quality here, which is often the case, not always the case, it doesn't have to use its ingenuity to be able to do better and get better value for money, raise the bar, and it will adapt. And some of the providers that can't will go, and that's a good thing. Thank you very much, everyone.
This is the time to formally thank Professor Barbara. It was a very stimulating lecture. The discussion, it is completely visible from the discussion and the interest of the audience. And yeah, I agree with most of the points that we've discussed in the thing. The public-private thing is one of the major debates that we are having. Basically, when we're talking about the stubbornness of maybe the bad reputation of the public system, it is also because of the budget allocation. So we don't have the sufficient budget for all these things. So most of the budget that is available is utilized in the preventive care, and that's why all this curative thing gets hampered, and that's why when we are talking about the medical negligence, etc. So ideally, yes, it should happen, and it can be averted, etc. But these are some of the issues. This is what we have in the system currently. That is the public-private. What to use, how to use, whether to use, for what to use, and which place. CMC, yes, of course, and some other place, of course, not. So it all depends. It's a context specific sometimes. So yeah, that's what I think. I'm not an economist, so I can't really talk about the economics per se much, but from the health system point of view, I think these are the issues. But it was a very stimulating talk, and all of us are definitely benefited. Thank you so much, Barbara.
Thank you, everyone.
She has given us a new perspective that systems thinking is really a nice way of doing it, which we have been missing.